We are grateful to be joined again by Dr. Tim Babinchak, who is an infectious disease expert and a member of St. John's Phoenixville, correct?
Correct. Yep.
So we've really appreciated, Doctor, your willingness to share with us, and uh, we're very interested to hear your insights on what's happened and where we are now, as opposed to 6 months ago when I think we spoke last. So the floor is yours, sir.
Thank you. Thank you again for having me, first of all. And thank you, everyone, for still joining and being interested in this ongoing saga. Bob and I have gone back and forth around the sort of agenda for today. So let me just start by leveling us out and saying exactly where we are today. Those of you that have been with me before know that I sort of look at things on a 6-month interval, and where are we today compared to where we were 6 months ago. And so with that in mind, where we are today, we're averaging, and this is a difficult number, this is the only difficult number, we're averaging around 48,000 cases of COVID a day. And the reason that I say that that's a difficult number is because that data is not being collected as systematically anymore. It's not that it's not being collected, it's not being reported. Many people are now testing at home, and so the actual number of cases that are out there are thought to be substantially higher, potentially twice as high, if not more, than what is being reported in those areas. So one of the questions that I always get, and it's always there, is so what number do we watch? And the number that the medical folks watch is the one that's most important to us, and that's sort of like church attendance, it's hospitalizations. Because the hospitalizations, there the testing is recorded and is reported, and is also the main factor that determines what resources we have to mobilize or how our hospital resources are going to be utilized in the near future. So ICU bed capacity, emergency room activities, all of those kinds of things. Those have been fairly stable and gradually decreasing over the summer months. And those are averaging around 28,000 hospitalizations a day. Now, that's a tremendous number of hospitalizations still in the United States. And associated with that is another very unfortunately stable number, which is about 400 deaths per day due to COVID. Now, when I say due to COVID, I'm saying this is not necessarily directly attributable to COVID, but people are dying. COVID is triggering their underlying diseases and their underlying infirmities, which is just pushing them over at this point. So the first question is why? Why are we still having this number of hospitalizations? And the best sort of way to think about this that I've been trying to talk to people is to think about it as an inverted funnel or pyramid coming down. And so what we know about the people who are being hospitalized are, number one, that they are still primarily those who are unvaccinated or are poorly vaccinated. And when I say poorly vaccinated, that means that they have not maintained their booster activity, not had the series of injections that are necessary or that have been provided in order for them to stay up. And the reason that I talk about it as an inverted pyramid is even in those individuals who have been boosted. I mean, think about where we are, as I said, 6 months ago to where we are today. 6 months ago, we were coming out of the end of an Omicron spike, all right? And that was the latest variant that was out there. And we didn't have vaccines necessarily that were very good against Omicron. As time goes on, the number of people that lose or gradually lose their immunity month by month, you can think about it, what we understand is about 10% of people per month lose their immunity, with those who are the most infirm, those that are the oldest, those that have chronic diseases, kidney failure, those types of individuals losing their immunity faster than the general public. So one of the other things that we've seen is that the age of the people who are being admitted to the hospital has actually not been decreasing, all right? So it is generally the older individuals. And so even with all of this going on, it's the fact that as you move down month by month by month, you have more susceptible people susceptible to being infected. And then with their underlying illnesses, because of their underlying illnesses, they become susceptible to being hospitalized and then dying. And so that's why that hospitalization number and that death number tends to remain fairly steady, because the pool of susceptible individuals increases every month, every day. And therefore, that is what continues to fuel that particular group and those particular numbers. So that's why we watch hospitalizations, and we've got a fairly steady mortality rate there. So the big question then becomes, is it going to change? And the short answer is probably not, all right? And when it does change, it's probably going to change in the wrong direction. So that brings up the next question is, all right, we've sort of made it through Omicron and things have leveled off. Is there another variant on its way? And the short answer there is no. So worldwide, what we've seen in the places that infectious disease doctors and everyone watches, we haven't seen any new variants of concern. Now, there are variants that pop up all of the time, but they're not fit enough in order to take over from Omicron. Omicron is the major one that is still circulating on a global basis. Now, because global vaccination rates are still low, there's still the opportunity that we will get new variants. And that's not just an opportunity, it's a certainty. What we don't know is when those are going to arise. So no new variants on the horizon. Stable as far as the numbers are concerned, mostly because of that inverted funnel or pyramid. So the next question becomes, well, what impact can we have? What can we do to try and make that? And that's what we continue to do by bringing out now, as we heard earlier, the bivalent shot that covers Omicron as well. And so the most important thing to do is to get those people who are still most susceptible, our older individuals, our individuals with comorbid conditions, et cetera, to continue to get their boosters. Again, the boosters aren't going to prevent infection. They're designed to reduce those risks of hospitalization and those risks of death, so that we start pushing people up toward the top of the pyramid, up toward the top of the funnel, and making the number of susceptible people smaller and smaller and smaller. If we do that, that then protects the larger group, because then we don't have as many cases circulating, and that's the best protection that we can have. Now, one of Bob's other questions is, why aren't we doing this? Well, welcome to the human race. All right, it's the same reason why we don't get flu shots, and people take certain responsibilities. In the best of times, we've been able to get about 60 to 65% of people immunized against influenza on a yearly basis, at the best of times. That leaves 40% of the population still vulnerable. And we anticipate, as infectious disease and epidemiologists, that that's about the best we're going to be able to get with COVID. Now, I want to make one distinction here, and that is I hear a lot of my colleagues talk about COVID and influenza. And one of the things that gets confused, one of the things that I think is important to remember, is that when we talk about influenza, we talk about a viral infection that occurs over a 6 to 8 week period that happens in our winter time and is fairly predictable. So we know when to give the immunizations to give people the best protection. And the reason that I want to get away from that is because of what we've just talked about. And that is, COVID isn't necessarily occurring in that seasonal spike. COVID is here all the time. So it's like pneumococcal pneumonia or the common cold. All right. And so I try to talk about it from the standpoint of a common cold, because that's actually a better way to think about it. Because we get colds all of the time. You get colds in the springtime, in the summertime. Colds happen all of the time. And the other reason that I like to talk about it in the perspective of a cold is that because they happen all of the time, increasing your exposure increases your risk. So we are going to see an increase in cases as we start to move indoors here in the Northern Hemisphere. All right. This is very well known. So when kids go back to school, they come home with colds, we get colds. When kids go back to college, etc., we go back to worshiping inside and closing the windows and all of the other stuff. Germs get passed around. So everything that I've said in the past still continues now for how do we keep our congregation safe, the same way that we have, and it works for COVID, a cold, influenza, etc. Make sure your HVACs are doing the best they can. Have people keep their distances, but most importantly, and this was one of the questions Bob put out there as well, most importantly, if you're sick or not feeling well, don't go to events. Don't go to church, don't go to Sunday school, don't go to choir, don't go. If you're ill, take that personal responsibility to stay home until you feel better, or know that you're not infected with anything, regardless of whether that's COVID or anything else. Keep our fellow human beings protected by taking a bit of personal responsibilities. And as I say to everyone, if you don't feel good, don't go. Please stay home until such time. And they ask me, well, what does that mean? What, I don't feel good? Do I have to have a fever? I'm like, no. If you don't feel the way that you should, please just, unless it's a necessary physician's appointment or something like that, it goes back to what I said in the very beginning of the outbreak 2 years ago. There are the things that we need to do, have to do, versus the things we like to do. And if it's a like to do thing, you need to make that personal judgment that way, in that way. So booster shots, yes, please go out and get your Omicron booster so that I can narrow the bottom of that pyramid and the number of susceptible individuals that can go into the hospital gets lower. Deaths, we have our treatments now. We have a very good idea of how to best take care of these individuals. The COVID aspect is not the major reason for most of the deaths, but it is the point that tips them over in these situations. And so that's why it's still incredibly important for us to limit the exposure that we have for these. The last thing that Bob asked me to address as far as COVID is concerned, and I'm going to make this as brief as I can, and that is the phenomenon of long COVID. So people who have had COVID and continue to have some symptoms. And these symptoms range from a wide variety of different things. Some are very well characterized, like the loss of smell and taste. We know that those are directly related to the virus and the way that the virus infects certain cells in our body. The best research that we have from the ear, nose, and throat doctors is that in the majority of instances, this is at most a 3-month sort of recovery period. So the latest research that we have suggests that by 90 days, 90% of people have their smell and taste back if they've lost that smell and taste. Not really anything that we're doing to hasten that process or prevent that process. It seems to be the need for the body to regenerate the cells that were killed by the actual infection, and it's just that body's time to regenerate that. That we know is directly attributable to the SARS coronavirus. The other symptoms, the fatigue, the muscle aches, the intermittent chills, all of those types of long COVID symptoms have been less attributable to the direct effects of the virus. And that's where, very much as we struggle with a lot of these viral diseases and these post-viral syndromes, we don't have any evidence, first of all, that it's ongoing infection or infection that hasn't been cleared, but rather that these are symptoms that are persisting in the absence of any ongoing infections. in this. One thing that we do know, and that is that the percentage of people that do experience long COVID is, again, less if they're vaccinated than if they are unvaccinated. So unvaccinated individuals tend to have persistent symptoms at about twice the rate of vaccinated individuals. So again, the better option is to be vaccinated rather than unvaccinated. Let me stop there before we talk about any of the others and address your specific questions. Bob, I think I covered everything. If there's something I missed, please let me know. Glad to.
I have a couple of clarifications for you. So talking about long COVID, one of the things that I am seeing, at least in media, is growing consensus that there are inflammation, system-wide issues, heart issues, neurological issues that are showing up. What is actually research show about that?
So we do know, we now have a very good idea of the parts of the body that the virus infects directly. Okay, and those cells that die. That's why I started off with the smell and taste aspects of it, as well as the lung aspects. So persistent cough, shortness of breath, things like that. We know that the virus directly affects those. And that recovery from that depends upon those cells regenerating themselves. What we look at for some of these other symptoms, the central nervous system, the heart, etc., are what we call off-target effects. And when we say off-target, it's the body is being, the reactions are not to the virus itself, but it is to the body's response to that infection. All right. And so just like with the deaths, if there's some underlying pathology that's already there, high blood pressure, heart disease, neurological problems, that gets exacerbated by the inflammation that occurs due to COVID. The body reacts to try and protect everything, and there are these off-target effects of that inflammation. And if there are underlying, or even if there aren't underlying problems there, that inflammation does a little bit of, can do a little bit of damage that may persist in those areas. And just as we were talking before, as some people experience their reactions to their vaccine, that same inflammatory response, that tiredness, that happens without the vaccine or happens in the natural infection. It's just that the vaccine is a very quick hit and goes away. If that inflammation persists in a human being, you see these longer episodes. And everybody reacts differently, just like they react differently to their vaccines. Some people have a strong reaction. Some people say, yeah, I didn't react at all this time. Okay. And so it becomes a very individual situation. And therefore, that's why it's very important that people who do experience these really explain that and do have those conversations with their personal physicians who know what their background is, to know their medications, who know their other illnesses, and can best adapt and talk with them regarding what their specific symptoms are, because this isn't something that is easily generalizable, because one person's heart inflammation is another person's chronic headache or whatever it is in that situation, and they need to be addressed specifically in their own personal health regard.
Okay, thank you. That's really helpful. Yeah, I think it's difficult when we observe things and don't know all the facts. I did get an email raising a question about, knowing someone who's healthy, 66 years old, got COVID, had heart complications, and died. And what we don't know is what's actually going on in that person's medical history. So those stories,
Unfortunately, yeah, still all too common, unfortunately, and yeah, that's why I'm trying to squeeze that pyramid to limit that as much as possible. And that's from a medical perspective, that's the best that we can do. And my mantra still is, if you're sick, stay at home, and if you're vulnerable, please consider getting vaccinated.
okay. There's a question in the chat. As to the psychology of vaccine avoidance, is there any peer review research that would give us a clue as why people choose not to be vaccinated, and what positive steps should and could be taken to change the minds of the recalcitrant, short of force, it says?
Well, we know force doesn't work as well. The psychology around that is it continues to be a benefit risk evaluation, a personal benefit risk evaluation. And we know that, and we know that for vaccines, but we know that there are still people who don't put their seatbelts on in their car. Okay. 20% of people still do not wear seatbelts, and they make up the overwhelming majority of fatalities in automobile accidents. And that is a benefit risk as to, I'm a safe driver. It becomes a very personal situation that looks at their beliefs and their belief system of the people around them, where that tends to occur. And so seatbelts is the one that I use all the time. Inner city seatbelt use is highest, rural seatbelt use is lowest. And that is because it's perceived that in rural areas, their chances of accidents are lower. We don't go as fast. I drive a big truck. Everyone has their own rationale around why that is. And it becomes a very personal, once you reach that saturation level, it isn't a population factor, it's a personal factor that drives that hesitancy. And so it becomes a one-on-one discussion to identify what's that personal factor that drives that hesitancy, because most of the societal or public factors have already been taken into account. And so the psychology around that is then addressing what that personal factor is. Is it fear of autism? Is it fear, whatever it may be? To the point of, I knew somebody who was vaccinated and they died anyway, so what's the use? Okay. Addressing, but that's why it needs to be addressed on very personal levels, because that remainder is is a personal situation, not a societal or a generalizable one.
Yeah. And so I think that's interesting. It relates to the emailed question from a pastor who was actually looking for some help in decision making and said, "We're thinking about going masks optional for worship. You know, what considerations should we look at?" And you know, it's interesting, and that's the one mitigation like we haven't mentioned because it's like the third rail of culture right now. I saw some research alluded to very recently. I didn't read the research, so I'm looking for some guidance on this. But the studies had shown that in cultures that were more amenable to masks and perhaps had requirements, we won't use the M word, that there were significantly fewer or lower rate of death than in cultures like ours, where you know, it's anathema to individuals to be told to wear a mask. Is there any truth to that? I mean, what do we know about whether how masks work, like say in a church environment?
Yeah, so very much so. And you know, we knew this before. That's how the mask became one of the prime mitigations. And so do masks work? Yes, absolutely. The filtration aspect is now really only one part of it. The major thing that masks do is prevent you from bringing these two things into contact with your nose, mouth, head, this area. When you're wearing a mask, you don't touch your face. And this is what transmits disease. This is what transmits colds. This is what transmits all of the things that, and the mask, more than anything, limits the amount of contact that your hands and your face get. Now, masks don't work to prevent the majority of infections. So the natural experiment that has been going on has been China, where they have had the most restrictive requirements around masking and social distancing and all of these things, with their zero COVID policy, which has failed miserably. All right. So nothing is perfect in that. So the guidance that I continue to give is, if you know that you're vulnerable and you want to take all of the precautions that you can for yourself, then yes, a mask is a good idea. If you are going into a situation where there are large, potentially groups of vulnerable people, masking is a consideration. Remember, we talked earlier about the sort of Swiss cheese effect of adding the different measures and how no one measure, a single measure has holes, but you put the next layer of cheese to try and stop, and gradually you get down. So the social distancing, the masking, all of those things, the HVAC activities, add layers of protection. If you know, my recommendations are, and this goes back to the personal circumstances, and it really becomes a personal circumstance decision, and why I can't support uniform masks in public transportation, et cetera, et cetera. And that is that if you know that you are vulnerable, then you do, just like we did around vaccine hesitancy, you do your risk assessment and say, what am I willing to do personally to protect myself? And then what am I willing to do personally to protect those around me in those situations? And that for our congregations becomes and it becomes the issue of what are you willing to do in order to protect, how far are you willing to go to protect those that are most vulnerable in our situations.
Thank you. That I think gives us some things to work with. One technical question that I'm curious about. I have seen media reports of people trying to proxy the air quality in a space using a CO2 meter to determine how many parts per million, whatever the measure is. And I think that's one of the questions that is very hard to know going into a space, whether it's an office, whether it's a church, whether it's a restaurant, is to have any idea of, we know ventilation works. We also know that we have no standards really for indoor air quality. So is there a way like that we can know that, for example, we do have adequate air exchange, in fact, beyond the quote statistics of the system?
This is the continual question for my HVAC folks, and that is, we actually do have indoor air quality standards, and indoor air quality standards for public places tend to have to be 6 to 8 air exchanges per hour. So total air exchange, so 100% of the volume of your building should be moved in and out every 10 minutes, essentially. And that's based upon what the relative occupancy is of that particular space, fire codes, et cetera. So that is dictated. And that's part of what, your CO2 testing, that's what the testing is supposed to, an adequately functioning HVAC system, it can easily achieve that. And that's sort of where we've been. And then so as we talked earlier in the epidemic, the question becomes, is that enough when you have a very communicable disease? And so the answer to that is we know that even with people are still getting colds, people are still, so two things, that's just another slice of that Swiss cheese. So the more air exchanges that you can accomplish, the better. That's why a year ago you heard me saying, keep the windows open as much as you can. All right, because that helps the flow through there. And why I'm very cognizant of everyone's heating bills as well, et cetera, where as a congregation, you got to make the decision, what am I going to be able to afford from a heating and air conditioning system that can increase that protection? So if I go from 6 to 8 air exchanges, that gives me a 25% increase in my air exchanges. At what cost? And so then it becomes that cost benefit analysis. So more is always better than less, but again, it becomes an individual activity there.
Okay. I'm thinking too of some of our older churches I've been a part of, where there's some sort of forced hot water heating and there is no air conditioning. The HVAC systems are fans running up in the top of the nave. And so what can churches in that situation do? And I guess the other question is, Do fans in that situation help or hurt?
So what we know from a circuit, that's an easy answer. Fans are fine. All right. They are neither helpful nor are they harmful in that situation. All right. The the I think I gave you that graph very early on. It's the length of time that you are in a situation with the greatest number of people who are infectious. Okay. And so that's why the first mantra is, if you don't feel good, stay home. And that's the biggest risk for all of our churches, is sick people attending events or coming to church. Those that don't know that they're ill, there's no good way to factor those individuals out. But if you know that you're not feeling well that Saturday evening or Sunday morning, please don't attend. That's the most important thing that you can do to protect yourself and protect others in the congregation.
Okay. I think I might add to that that it would also be a good idea to, if you have likely had some kind of exposure, even if you don't feel sick, at that point, you should also.
If you know you've been exposed, right.
Okay. Well, so sort of my last question, and I think this is really as much for all of us as for you, but we'll let you start off, is, our culture is just, it's our culture. There are cultures where people for years have been wearing masks in flu season and cold season. Not that there is such a thing, but and it's, we have our certain attitudes about how we do these things that are our culture. But as Christians, should we have um, any any view different than just simply the fend for yourself attitude that seems to be coming from a lot of our leaders?
Yeah. uh, I am probably the least uh, qualified in this regard, other than what you learned in catechism as a young Lutheran. And for me, it goes back to when Jesus was asked, what is the highest of the commandments and what is the first law? And that is, do unto others as you would have them do unto you. Treat others as you want to be treated in that situation. And that, for me, I think that's my overwhelming response to that question, is to, what can we do? And that, to me, that's non-denominational. That's not Christian or otherwise. I don't know of any religion that necessarily espouses the fend for yourself uh, sort of attitude, but a responsibility that we have for each other in this. And so for me, that's my personal view, but that's also my public view. And that is that, hey, just treat other people and do things the way that you would want to be treated. And judge not, again, lest you be judged.
Amen. I think back to an analogy you've used in the past about that surgeons don't wear a mask to protect themselves; they wear it to protect
Others, yeah.
yeah. So I'm just wondering. We have certainly some theologians in our midst here. I'm just wondering. Well, Tina, you have your hand up, so jump in.
Thank you, Dr. Thank you, Bob, Sue, and Jonathan, for keeping us all together and for keeping us informed. I have a testing question. I have a friend, she's about 69, not in the best of health, was on vacation in Florida and caught COVID, her and her husband. They were with family and friends and ended up in a hotel isolating for, I think, about 7 or 8 days, and then they were able to come back to Ambler. They live in Ambler. Last week, I think she told me that she's, maybe Monday, she says she's still testing positive, and that her doctor said that a person can continue to test for quite a while, even months. And she's fearful that when she's ready to go on vacation to Europe in November, that she may continue to test positive. She said that the doctor can give her some kind of slip saying that she's okay. But I also question her, how do you know that you haven't been reinfected and that's why you're testing positive again? Is it true that you can test positive from an original COVID infection for months?
Okay. So let me let me take this in parts, and that's an excellent question, because that still occurs. So, and this goes back to not knowing individual circumstances. So the vast majority of individuals who do not have some sort of immune problem or are on a medication that alters their immune system will clear their infection within 10 days. Okay. So from the time that they're symptomatic until the time that they would have a negative test, 95% of people will have a negative test after 10 days from the time of symptoms. That doesn't apply to people who have immune difficulties. And so not knowing an individual's circumstances, so the only people who tend to have persistently positive tests are those that have immune defects, either known or unknown in those situations. All right. So I can't speak to any single particular case, but that those, you're doing the right thing. Have that conversation with the doctor that knows your situation the best. But a persistently positive test in the absence of those defects is actually a reason for that person to then be seen, because that suggests that there may be something that they don't know about that needs to be taken care of in that situation. Okay. And again, so the answer is the same for both, and that is, that's best between an individual and their doctor, and they need to look at that. There's an underlying question that I just want to address there, and that is the accuracy of these home testing. We've all gotten them in the mail. The government has sent them out. And what we do know, this has been documented very, very well, is that the use of the home testing is extraordinarily accurate. It is within 1% of the testing that's done in the hospitals. And we've actually, the most convincing research that we've done was actually done here in Philadelphia at the Children's Hospital, where they took 8-year-olds to 14-year-olds and gave them the tests to do themselves, the nasal swabs on themselves, 8 to 14-year-olds, and then tested them at the hospital setting. And there was test concordance. The tests were the same within 1% of each other. So if an 8-year-old can do it, I'm pretty sure most everybody that's getting either a positive test at home or a negative test at home, those are accurate.
Okay, thank you.
She does take a lot of medication every night. Again, I don't know her health history. She has been vaccinated and fully boosted. And how long should you wear a mask? Those K9, N95s, K995s, how often should you dispose of them?
So once those masks are very effective until such time as they show evidence of wear or get dirty, then they should be changed. All right. So there, it depends on, I can't tell you a time because it depends on how the individual uses them, wears them, frequency, et cetera. But if there is visible wear or visible soiling, they should be changed.
Sometimes it depends on if I wear lipstick, then I can't put it back on.
Thank you. Great questions. Pastor Suloff.
Yeah, I actually have a question on the kind of other end of testing. And I'm kind of embarrassed to even say it because I still feel bad about this, but we carpool to school. And my son's friend was in the car on Friday, hung out. Now they were outside the whole afternoon before he went home. And then I get a text message Saturday morning to tell me that everybody in the family has now tested positive for COVID. So I was like, what the heck do I do here? And my son's mother's freaking out and all that kind of stuff. So, especially with it being Saturday morning, I took a test first thing Sunday morning. I came up negative. When my son got back Sunday evening, he took a test, came up negative, and then we also did tests. We both did tests Tuesday morning, and both of us were feeling fine, all that kind of good stuff. We were both feeling fine. So I took him to school Tuesday morning. We haven't done the carpool. His friend has apparently been at school. That's between him and his family as to when to return. We're holding off on carpool until next week. But in terms of testing, what's the timetable with potential exposure
Right.
and that kind of stuff? Because I know that you can be contagious before you're actually showing symptoms.
Exactly. And this is, that's a very important question. So when there's been an exposure, okay, and a known exposure as there's been in this case. If you're, so this, let me do this in two parts. If you develop symptoms, test. Okay, that's the easy one. No symptoms, exposure, and we'll use your example, Saturday morning. Testing Sunday is good just to show that you have a negative baseline. But then you did exactly the right thing, which was waiting for a few days, because even if your exposure was Saturday, it will take 5 to 7 days before the virus will have multiplied in an individual, in an exposed individual, for it to be detectable, even if asymptomatic. So testing Tuesday or Wednesday would have been perfect. You did exactly the right thing. And that's what I tell my patients. Set up a baseline. If you have a known exposure, take a test to know whether you're negative now. and then wait 3 to 5 days and then test again. If that one's negative and you don't have symptoms, you're in the clear. And that is also the same for if you've been exposed. When do I feel, you talked about, somebody going back, if I've been exposed, when can I go back to my activities? And I say the same thing. If you've been exposed, it's that same 3 to 5 day period. You're waiting to see if you're going to develop symptoms. If no symptoms, negative test. No symptoms, negative test, go about your business. That's the most conservative way. That's the way that we can best, again, try and narrow that pyramid to keep as little virus circulating out there as possible.
Excellent. Thank you so much. You just made me feel a whole lot better.
Thank you. That was a great question. John Baskin.
Dr. Babinchak sort of touched on this already, and Jonathan's question was very similar to my own, but going back to the initial comments Dr. Babinchak mentioned, we're missing a lot of data because people do now test at home. And the reporting of that and the lack of reporting of that perhaps now could be considered a disadvantage because we do not know, or is it an advantage to have the home test kits because we've avoided local government or federal government testing centers and said, everybody gather here and we'll test you. We've avoided that. But also in Dr. Babinchak's lecture, he said, if you don't feel well, stay home. Then you can test yourself. So in terms of a cost analysis, it's probably a factor of things that come to advantage or disadvantage. I'm not trying to answer the question because Dr. Babinchak sort of touched on it initially with Jonathan's question. But I guess overall, there certainly appears to be a real advantage of having the test kits there at your disposal.
Yeah, you're absolutely right. I didn't mean to imply that the having the tests should be a disincentive. And from an epidemiologic standpoint, you're absolutely right. It takes away the number of cases that are identified. But that's why in my opening comments, I talk about what we watch are hospitalizations, because that is the stress on the system. And when we see that start to go up, we know that the cases are out there. This virus is out there, it's circulating, it's going to circulate at the level of that susceptible population. So the wider the base of that pyramid, the more circulation, the more transmission that you're going to get, regardless of what the official cases numbers look like. But that's why if we squeeze that transmission, then we'll start to see inroads on that hospitalization. The deaths aren't changing dramatically, mostly because of the older population, the still unvaccinated percentage, and the infirmities. So we are projecting, epidemiologists, to the best of their understanding, somewhere between 200 to what's been 400 deaths per day in this situation. All right. And by in this situation, I mean in perpetuity. Okay. Not going away. Introduction of new variants and things, all as I've said to a classical music friend of mine, that is, the movement is going to change, but it's still the same symphony. You're going to have rapid movements, you're going to have slow movements, you're going to have rapid movements, but the symphony is going to continue.
Okay, that's a great analogy. Thank you. Pastor Owen.
Yeah, hi guys. I had a question about vaccination, Dr. Tim. I've been jabbed 4 times already. I had my second booster last May. Now, I understand that the vaccines that are out there now are these bivalent vaccines. So when do I get the 5th jab?
When you're ready, right now.
Okay.
Okay. Yeah, that's my squeeze in the bottom of the pyramid. You know where you are in that based on your own health situation. And so the older that we are, the faster that decline. And that we talked about the vaccine hesitancy, and it's all, the young people are like, I'm immune to this. It's not so bad. And we're right, it's not so bad. All right. Bob asked me to say a few words about monkeypox as well. People aren't concerned about monkeypox because it's not smallpox. When 30% of people are dying, that risk and that their reasons for not getting something change. When it's 400 people a day and it's been going on day after day after day, you get this numbness that sets in. And Bob, we talked about monkeypox a little bit, of how it is the sensationalism of an event that brings it to the forefront of the news. All right, dog bites man, no big deal. Man bites dog, you've made the news in that situation. So, I'm going to stop there because I'm cognizant of everybody's time as well. But I'm here. I have all of the time that you need. I'm more than happy to continue.
Okay, I see you, Pastor Suloff, but I have a question first to follow up on that. Do you see us being then in a situation, if this is going to be the situation kind of in perpetuity, are we going to be getting annual or semi-annual COVID shots like we get flu shots and pneumonia shots? And
yeah, so that's a very good, that is the, as I've talked about the 6-month sort of timeline that I go on, that's our next chunk of 6 months. So what we've learned, Bob, and this I hesitate to do this because it goes into the, using the word twice in the same sentence, the vaccine hesitancy aspect of it. We know that people who have been adequately vaccinated, their risk of hospitalization and death, even with just the first set of vaccines, is 70% or greater. All right, so without boosting, that's the vast majority. Now, you're always going to have, the infirmities change all of that. But we do know that the first set of vaccines offers close to 70% protection, even with the Omicron and these new variants, to hospitalization and death. So now we're working on that 30%. And so now you get your booster and you're trying to get 90% of that 30%. And that's where the diminishing returns come on a year after year basis. And this is why I also talk about it outside of influenza. We know influenza changes on a yearly basis. So the answer to the question is that whether or not we get yearly boosters, or what that interval of boosters is going to be more dependent upon the viral changes than it is around seasonality. All right. So if Omicron remains the dominant virus, then you're not going to get a vaccine for a new variant, you're going to boost your Omicron because you're still losing 10% every month. And so by a year, your levels of protection are not going to be as strong as they were. And your individual circumstances will dictate in that diminishing return what that looks like. And that's why we can't anticipate that as boosters continue to roll out, that we're going to see this 70, 80, 60% uptake all the time. That number is just going to continue to decline.
Okay, thank you. John.
I think this is a pretty quick question. I actually have my appointment for my booster scheduled for Monday, but I also have my flu shot scheduled for the same thing. Any problem getting the two?
One in each, no
Perfect.
problems. All right.
Awesome. Just
All right.
wanted to make sure. Great.
And so let me put it this way. No problems from your developing immunity standpoint, okay? If you're one of the people who reacts, you're going to react, okay? Because now you're getting two chances. What I tell people is you're kicking your immune system in the butt twice rather than once, all right? And so you're going to be sore twice rather than once.
I guess I'll make sure I have plenty of Law and Order reruns.
There you go. Plenty of
DVR.
fluids. We do know that fluids tend to help. So if you keep yourself hydrated, that does tend to help.
Okay, thank you. Wayne.
Thank you.
Yeah, my question. Yeah, my question is relatively quick as well. And I can tell Jonathan that just from personal experience, I got my flu shot last year with my first booster, and this year I got my flu shot with my bivalent booster. I've been shot 5 times with the boosters, the boosters and all that, and I've had 2 flu shots, and I've never had a reaction to anything. I mean,
Lucky man.
none whatsoever. But my question, it goes back to your 400 deaths a day. That's an interesting number to me, and I just wonder in terms of medicine, like of all heart attacks, strokes, what's that comparable to? Like what else happens at a rate of 2,000 a week?
Okay, so that it's comparable to the number of deaths that we see in the peaks of the worst flu seasons.
Okay.
Okay.
The worst flu season.
Yeah.
Nothing else. So it's still a higher number than almost anything else. Okay.
Yeah. And and like I say, we're now to the part of, are they preventable? And that's why I started in the beginning. And I just want to take a minute here. And that is, that's why we're saying we're looking at it as this being 200 to 400, because we don't have a way to prevent those deaths anymore. All right. We've got fairly good therapies. We've got good vaccines. This is just a new disease that's been entered into our society, just like HIV entered into our society in the late 70s and 80s and continues to kill people today. All right. But it doesn't kill people at the rate that it did back then. Eventually we'll get there, but we just haven't gotten there yet. But we've got a new disease that's never going to go away. The epidemic purport aspects of it have gone away, but there's always going to be this background excess deaths that a new disease has brought to us.
Even beyond disease, I mean, just, how many people die of heart attacks a day or a week?
Yeah, not that many.
Not that many. No?
Not that many, fortunately.
That's good. That's good to know. I just wondered. Thank you.
Yeah, I think I read or saw on the news that COVID is like the 3rd or 4th leading cause of death among adults in America.
Yes. Yeah, on a year-on-year basis.
Right, right.
Yeah.
Lynn. You're still muted.
Sorry, I couldn't get to it fast enough. My question is, I have friends telling me that they are not going to get the latest booster because it has not been tested on humans.
They've all been tested on humans. All of the boosters, all of that has gone through the same rigorous activity as all of the others. And as you've heard me say here over and over again, the most remarkable thing in all of this is the safety and the diligence that's gone into the the research into these vaccines. So they most definitely have, in all of the populations, even as you've heard this past week with both Pfizer and Moderna asking for approval for it to be done in children, and the children have been tested as well.
Thank you.
Yeah, it's one of those pieces of misinformation that floats around. We're swimming in it, I think. So my last question, since we're kind of at time, I know you don't have a crystal ball, but what are you thinking? You know, we've tended to, even though it's not seasonal, buy into the seasonality of winter being bad, and I think we were warned about that a number of months ago. What do you think we're looking at as we go into the colder months?
Yeah, you're right. I don't have a crystal ball. And the prognostications of the experts for the past 2 years of these huge activities of combinations of flu and COVID and the apocalypse really didn't necessarily come through. What I can fairly confidently say, Bob, is that it is likely, as we move into the colder months, that we're going to see an increase in that background activity. And again, here is where as hospital teams and hospital administrators, et cetera, we watch that hospitalization rate very carefully, because that gives us an idea of what community transmission is looking at. And it is being treated in the medical community as an early or on a par with a resurgence of the flu season. So our staffing, our ordering, all of those kinds of things are on a par for the winter months, as we would usually do for influenza. And that tends to be about a 20% increase. We anticipate a 20% surge in that. So we set our staffing, we set our bed availability, we set our inventories at about a 20% surplus in that regard. I can give you what we're doing. That's about the best that I can say. Okay. That's in the absence of a new variant. And fortunately, for the last 6 months, that's what we've seen. We have not seen a variant that can overtake Omicron. But that's why it's important that people should be getting these bivalents, because that will boost our immunity to Omicron and keep that transmission low.
Okay, thank you. So I realize there's one question in this email that I did not ask you, which is the question about, you know, where are the best places to find usable information? For example, who's tracking hospitalizations in our area?
Yep. So the hospitalization numbers are still available through the Pennsylvania Health Department, and that website is still active, and you can drill down into specific county and regional activity there. That's one that I use. Quite frankly, if you're looking for national trends for travel or relatives or others individuals, the New York Times still has a very good interactive website that combines both local health department and other resources and it gives availability on both vaccination rates and hospitalization and case rates across the country. They track cases, hospitalizations, and deaths on that website. And the CDC website as well continues to provide that information on a granular level. Now, it goes to, and I always put this caveat in there, and because it was the first computer class I had to take as a young man eons ago when computers came in, and it was the old GIGO saying, and that is garbage in equals garbage out. So it's only the information that we have is only as good as the reporting systems that we have. And that's why I tend, you asked for reliable, where can we still find this information? Those sources continue to and have been consistent throughout this time period. And so PA State, CDC for national, New York Times gives you some granularity in those areas. Those are the first places that I look to for the statistical activity.
Okay. What do you think about the value of the CDC's community levels versus the community transmission?
No, that's it, and that's where the garbage in, garbage out comes, and that is the CDC's information comes primarily from sites that report on a continual basis, not just for COVID, but they are selected sites that monitor respiratory diseases, that monitor now polio, that monitor monkeypox. And so that information goes in regularly. What we've seen over time because of the budgetary constraints is that other health departments or smaller health reporting activities have dropped off. So you lose that granularity for Berks County, all right, as an example, or Delaware County in Philadelphia that doesn't even have a health department. All right, so the trend data, the national trend data for the CDC and for Pennsylvania are fairly consistent. It's when, as municipalities don't report, you start to lose the fineness to that. Major trends are still the same, and that's why we watch hospitalizations, because that number, everybody keeps a close eye on that because that's very tightly linked to what their money and their expenditures are going to be.
Okay. All right. Well, thank you very much, Dr. Tim. We appreciate your time, and we'll talk to you in a few months unless something.
I'm always here. Always here whenever you need me. Please feel free.